second annual In-Step Center Pilot Funding Pre-Application Webinar. We're glad that we have a few folks with us. Now we expect a couple more folks, and then we're recording for people who are not able to make the meeting. Next slide. Okay, so just as far as a couple of logistics, feel free to share your questions and comments in the chat as we go. You can enable live captions on the Zoom bar if you wish. We are recording and we'll post it on the center website and YouTube. I think as you got the Zoom pop up acknowledging the recording, but if you feel more comfortable turning off your camera, you're welcome to do so. Next slide. Okay, so I'll do a brief welcome and introduction to the center, and then Dr. Burke will talk about team effectiveness research. Dr. Stadnick will talk about D&I research, and then I think we'll turn it over to Dr. Sklar, who will talk about the pilot grant aims, logistics, and process, and we'll leave time at the end for questions. Next slide. Okay, so I'll just quickly, we can go around and do introductions for our center leads. I'm Lauren Brookman-Frazee. I am one of the center directors, and I lead the administrative core of our center. Unfortunately, Greg Ahrens, our other center director and methods core lead, is unable to be here. But I will turn it over to Sean to do her own introduction.
Hi, I'm Sean Burke. I'm a professor at the University of Central Florida. My background's in industrial organizational psychology, and I co-lead the methods core.
Thanks, Sean. Nicole?
Hi, I'm Nicole Stadnick. I am an associate professor in the Department of Psychiatry, along with Lauren and Greg. And as part of the center, I co-lead the admin core with Lauren.
Thanks, Nicole. Marissa?
Hi, I'm Marissa Sklar, also in the Department of Psychiatry at UC San Diego. And I also co-lead the methods core.
Thanks, Marissa. And I want to make sure to leave time for Liliana and Anna to introduce themselves. Liliana.
Hi everyone, I'm Liliana and I'm a research assistant working for the admin core.
Anna.
Good morning, everyone. I'm Anna and I am the research assistant on the methods core.
Thank you both for organizing this webinar. Next slide. Okay, I want to first acknowledge that we had five awardees in our last round, and I won't go through all their names and projects, but you can see that it includes primarily early career investigators from multiple institutions, and we're excited that they are launching their projects, and we'll be providing them opportunities to present updates on their projects in the fall. Next slide. Okay, so just so we know who is here, just and get to know each other, if you could please share your name and your affiliations in the chat for our attendees. A minute to do that. Welcome, Rachel. We're excited to have you here. Welcome, David. I already have 2 institutions represented. Hi, Yesenia. Welcome. Welcome, Julia. You're a few time zones away, so we understand that you need to head off a little bit early. We're glad to have you here. Okay, next slide. Okay, so the INSIP Center is really kind of based on and grounded in the premise that children's mental health is a public health priority. And you know that multiple public service systems are involved in caring for children and adolescents with mental health and developmental needs. And those systems in which we're initially focused on includes public schools, outpatient school-based mental health services, child welfare services, medical services, and there are others. These are the service systems in which we are starting our research. Next slide. So continuing on with our premise, it's really based on the fact that there are multiple evidence-based practices, or EBPs, that have been developed and identified as effective to addressing mental health and developmental needs, but they aren't necessarily routinely used in usual care or routine care. We also know that teams and teamwork are essential to providing mental health services, and to implementing evidence-based practices within services. So we argue that integrating team effectiveness research and implementation science has the potential to accelerate the quality, improving the quality of care and the effectiveness of care. So that's really just kind of the grounding or the foundation of our center. Next slide. So if you haven't already done so, we encourage you to check out our center website. We are increasingly including resources, new resources on the center website. There's information about the RFA on the website. There's also opportunities to request mock grant reviews or consultations. So if you aren't already linked to our website, there's use the QR code, or we can also add the website into the chat. Next slide. Okay, here is the specific request for applications that you can use the QR code or find it on our website under that section on our website if you want to follow along during this webinar on the request for applications. Next slide.
Okay, so I guess that's me.
Thanks, Sean. We'll turn it over to you.
Sure. So I'm just going to give a very brief introduction to some of the basic concepts that we talk about in team effectiveness, with the hopes that this will help to provide a foundation for thinking about what you want to focus on if you decide to go after one of the proposals. Go ahead and go to the next slide. But before I get started, I think there's going to be a Zoom poll that comes up, and if you can just respond with kind of your current level of experience with team effectiveness research, so we can kind of see where we're at. Okay. I think that's probably about everybody. So it looks like, I don't know if you guys can see the results or not. Here we go. So most of you guys are novices, and we have at least one person that has some level of experience. Novices are beginning, so a little bit of a mixture. All right. All right, if you can go ahead and go to the next slide. So what I wanted to start off with, so for those of you that have some knowledge or intermediate, some of this might be pretty redundant for you, but I wanted to start off by kind of setting the groundworks and clarifying kind of what our boundaries are. And when you're thinking about this, what we mean when we say a team. And this is a longer definition here. I'm going to give you a shorter one and then kind of pull out some high points in this one. So really a team is a set of two or more individuals, keeps popping up, a set of 2 or more individuals who are working interdependently, and that's key, interdependent. So there needs to be, I need to rely on you in some way, shape, or form in accomplishing my task for me to think about it as a team. So 2 or more individuals who are working interdependently towards at least one or more common goals. This definition also highlights that teams are embedded within organizations. And so that organization kind of sets the context and constrains kind of what they can and can't do to some extent. Go to the next slide. So I talked about one of the key things that I wanted to hit on is this notion of interdependence. Because what I'm going to talk about today, the more interdependent or the more that I need to rely on the other people that I'm working with on my task, the more I need to do that, these concepts that I'm going to talk about become more important. And this is a taxonomy that's out in the literature. It's been around for a long time. And I'm not so much focused on the fact that you need to know exactly like what the different labels are, but more to kind of frame that when you're thinking about the context you're operating in and whether or not what you're looking at is a team. These are some of the things to think about. So the first level is pooled, and it's really independent workflow. So to me, that's maybe at the very low level. I don't know if I'd even consider that a team. So the diagrams on the left kind of show it. So within that context, you've got 3 individuals. They're kind of they're working in the same context, but they're not interacting with one another. The only way that they might be considered a team, very loosely speaking, is that they have some type of shared outcome. Really, when we talk about teams, what we're talking about are these other 3 levels. So sequential interdependence talks about that there's interdependence, but the workflow is going one way. So think about an assembly line. So my output begins to be your input and your output begins to be the next person's input down the line. Reciprocal interdependence, really now we're talking about kind of that bi-directional workflow. So if you think about within a hospital setting, you could think about handoffs, right? So I'm handing off, I'm exchanging some information with the person that's coming on the next shift. They're probably, hopefully they're also exchanging information back with me to make sure that we understand one another. Or perhaps in a mental health setting, a provider is working with a parent on an action plan. And it's really that 2-way back and forth interdependence that's happening there. The last level, team or intensive, really just talks about it's much more simultaneous. So kind of everybody's working with everybody at different points in time. And you've got this kind of multi-directional workflow. Go ahead, next slide. When we think about, so teams have to be interdependent. The literature early on, when we start to think about teams, we talked about input, process, and output. And that's kind of how we think about them. What's on the screen right now, when I undo the box, is going to be very messy. Again, it's a integration of several different models. I just want to give you guys a flavor. Early on, we started thinking about inputs. That's what you see on the left-hand side. So things that impact, if I'm working in a team, I need to think about the member characteristics, the characteristics of the team itself, or the characteristics of the task and the work context, obviously. Early literature looked at inputs and how that related to team effectiveness, which at that point, that's all the way on the right-hand side, at that point was really contextualized as the quantity or the quality of whatever output that they were working on. More recently, we also talk about satisfaction. We talk about the viability, which is the degree to which I want to come back and work with this same team again, if given the opportunity. And then on the top of this, you see the idea, again, that they're embedded within an organizational context. So we have that environment's going to impact how they work together. Early literature knew that these inputs produced different levels of team effectiveness, but there wasn't a real focus on this kind of black box that's in the middle, or how do we get from point A to point B? And you can go ahead and hit the next. So the last, goodness gracious, probably at least 50 years or so, where the researchers focus is really on unpacking how do teams work together? How do we get from these inputs to these outputs? And really the focus has been on, we do it through processes. Hit the button one more time, maybe. Yeah, okay. We do it through processes, which are really these dynamic actions that typically are behavioral in nature, and they contribute directly towards task accomplishment. So we do it through processes and emergent states, which tend to be more affective or cognitive in nature. I'll go into all these in a little bit more detail in a minute. Emergent states do change over time, but they don't change like on a moment to moment basis. So if we think about a process such as communication, obviously that changes as we're talking. If we think something about something like trust, right? It does change over time, but it's not that moment to moment thing. And so what we see the literature talking about is the way that teams work together through team processes. Like I said, primarily behaviors. Those team processes serve to impact how I think and how I feel. That's the emergent states. That relates to team outcomes. And then those outputs kind of come back around. This is a recursive cycle. We often don't investigate it as such, but it's a very dynamic cycle. And then on the bottom of this, what you see is the fact that usually when we try to intervene in teams, a lot of times where we intervene is within those processes or states. And so there's been a number of evidence-based team interventions, and that's not all of them down there at the bottom, but it's a sampling of the idea that then we can take evidence-based interventions to impact the how to hopefully result in better effectiveness. All right, next slide, I think. All right, so that was kind of my really short groundwork, if you will. What I want to spend the rest of the time is really on giving you guys some basic ideas, some basic constructs in terms of unpacking the how. So how do teams work together? What do we know are the constructs that are important for team effectiveness? And some of my colleagues talk about the ABCs of teamwork, to keep it simple. So A's are your attitudes, your affect. Those are some of those emergent states. Behaviors tend to be our processes, and then cognition is just that, it's cognition. And those things work together to elicit team performance. And so I'm going to go next and kind of begin to unpack some of this. So in terms of the knowledge requirements, what I've got listed here are some of the ones that we see most researched. The first three on here that we know about. So we know that effective teams have knowledge of their mission, their objectives. They have an understanding of what the norms are and what resources are available to them. They also have an understanding of roles and expectations of each member on that team. And that's something that often gets missed in practice and is something that's a fairly easy fix. The other knowledge requirement, and this might seem like a given, is I need to have individual task proficiency. So if I don't understand how to do my task itself, it makes it very hard for me to effectively work with others on that task. Okay, so those first three things really reside more at an individual level. The last three on here, I'm going to go into more detail on because these are really what we refer to as team cognition, and they really represent more of a shared team property. If you go ahead and go to the next slide. So the first one that I'll talk about is shared mental models. This refers to mental representations that the team members hold about themselves and the task and how the team works towards that task in the environment. This is important because researchers found that when we have a shared understanding of how that task works, what the team members' roles and responsibilities are, and how they interact towards that task, it allows us to better adapt our actions in difficult circumstances. It's also been shown to be an underlying foundation for coordination, especially in situations if you're under a lot of time pressure and I can't explicitly tell Lauren, hey, I need you to pick up the slack, or I need you to go to the left. If we have a shared mental model about the task itself, then she can go ahead and be proactive in that. Next slide. The second cognitive construct that we talk about is transactive memory systems. And this really, the formal definition I think is down there at the bottom, but it's really talking about one of the cool things about teams is I don't need to know everything, right? We often bring people together in a team because they have different areas of expertise. And transactive memory systems kind of talks about taking advantage of that expertise in the sense that it's an awareness of who holds what expertise on the team. Well, it's the knowledge of who holds what expertise and an awareness of that. This helps because it reduces my workload, right? If I know that Marissa's really good at statistics, then maybe I'm not so good. I don't need to go and learn a whole bunch of stuff about R. I can reach out to Marissa and ask her questions about R. So it's that distribution of knowledge throughout the team. And it helps me to decide who to pass information to. So I'm not overloading people. It also helps me to decide if I'm making decisions or problem solving, how am I going to weight the information from my team members that are coming in? And then it's also been related to a number of outcomes such as team learning, team knowledge transfer, team satisfaction, and team effectiveness. Next slide. The last cognitive construct I'm going to talk about is situation awareness. And there's this really nice definition on the screen, but basically it is knowing what's going on around me at any particular point in time, right? So the perception of environmental elements and events with respect to time or space. So what's going on? What does it mean? And what does it mean for what I'm doing on the task? It's important within teams because often having an understanding of having good situation awareness allows us to identify when we need to adapt our actions, is one of the areas that is key in. And it also might help me to understand when I need to step in and help somebody else out. Okay, next slide. So that's kind of the high level view of the cognition part. The next part I wanted to touch on really briefly are kind of the processes that we talk a lot about within teams. So probably the most recent taxonomy is done by Marks and colleagues, and that talks about 3 different categories, high-level categories of team processes, and that's the transition, action, and interpersonal. Transition processes are those behaviors that the teams tend to do during planning times, if they're self-reflecting. So we talk a lot about analysis of the mission, what needs to be done, specification of goals, specification of strategy, kind of setting our conditions. Action processes, on the other hand, are those things that are being done while the team is directly working on the task itself. So coordination, there's a lot of monitoring of goals, monitoring of the system, monitoring. Good teams monitor one another and step in to offer backup help and behavior when needed. And that can be in the form of knowledge. It can be in form sometimes of actual action. And then across both of these things, we talk about, because we're working with other people, there are these interpersonal processes, right? So if you're within a team for any amount of time, you're probably going to have conflict. And conflict isn't necessarily always a bad thing. So we talk about conflict management. We talk about motivation and confidence building and managing of our affect. The ones that I have down here on the lower right-hand side are ones that have been around for a really long time. They're not specifically called out in this most recent kind of taxonomy, but team leadership we talk about a lot in terms of setting the conditions for teams. Adaptability, closed loop communication talks about a specific type of communication that helps me to ensure that the message I sent to you was actually understood. And then task related assertiveness. Now you can go to the next slide. Okay. So I'm trying to keep an eye on my time here. The next thing I wanted to talk about were the affective emergent states. So how do I feel? And within teams, there are more than these, but these are the ones that kind of we talk about a lot and that there's a lot of evidence for. So the first 3 I'm going to just briefly highlight, and then I'll go into more detail on the bottom 3. So collective efficacy refers to the belief that the team can accomplish whatever task it was given. Collective and team orientation talks about feelings towards working in a team. Some people like working in a team much more than other people. Team identity is just what it sounds like. So the degree to which I actually identify with the team and feel a part of the team. The last 3, go ahead and go to the next slide. I'm going to go into more detail on, because I think these are really, well, they're all important, but I think these are really important, especially when we start talking about mental health. So one of probably the most research aspects of affective states is team cohesion. And it's the bonding together of members of a team or of a collective. And that bonding together is it's motivational in nature. So it's what causes us to, stay beyond and do things when we just want to go home and, we're tired, we're stressed. But that bonding continues to kind of push us and push our effort forward. And within teams, we talk about 2 different types. So we can talk about that you can have a bonding or quote unquote, an attraction to the task itself. And that's what I tried to represent on the left-hand side of the screen. So I believe that the task that I'm working on is very meaningful and it's going to have an impact. And therefore that bonding is to the task. We can also talk about social cohesion, which is irrelevant of the task. I could hate the task, but I really like the people that I'm working with. And so I'm bonded to those people that are in my team or in my group. And because of that, I go above and beyond. Team cohesion facilitates information exchange. It facilitates a lot of good things. And both of those things, we talk about both of those things, both task and social cohesion being important to teams. Next slide. Okay, the other affective emergent state that I wanted to highlight is trust. This really isn't any different at the team level. If you understand trust at an individual level, you understand it at the team level. So it's really the willingness of one person to be vulnerable to the actions of another party, based on that, basically that you're going to do what you told me you're going to do, and you're going to do it without me having to stand over and check you, right? So two things: if I have to watch you and monitor you, it's not trust. Second, if there's not some perception of vulnerability or risk in what you're trusting them to do, it's not trust. If you go to the next slide. In teams, we talk about 3 different types of trust. So we talk about cognitive trust, which tends to be the first to form in teams. And that's based on my knowledge about your competence, your integrity, your reliability. Affective trust is the second type that we talk about. Usually comes after cognitive trust. Once they're formed, they are reciprocal and they each go back and forth. But affective trust is built on my emotional investment. So I believe that you generally care about me. You have a concern for my welfare. You're not going to go, kind of stab me in the back. The last thing on the bottom there, swift trust, is a newer type of trust that we talk about. And it originated because there are some teams that they come together very quickly. They haven't worked together before and they have to kind of hit the ground running. And so people began to ask, well, these other 2 types of trust form over time. So how do people make those initial trust judgments? And so the notion of swift trust began to come out. And the literature suggests that with swift trust, it's using a lot of kind of superficial cues and social cues to make attributions about probably these cognitive and affective kind of things. Next, yeah, thanks. The last state that I wanted to highlight is psychological safety. This has received a lot of press within the last couple of years. It's been shown to be related to team learning. Leaders can play a great role in facilitating this. And it's basically, it's a feeling that my team is safe for interpersonal risk-taking. So important within many high-risk environments. I would argue especially important also within mental health, because it talks about that I feel free to voice my opinion, to speak up, that I'm not going to get dinged either formally or informally by my team members. And so it is in some ways a little bit similar to trust. The difference is that in trust, I'm talking about giving the other person the benefit of the doubt. Psychological safety is about the belief that you think others will give you the benefit of the doubt. Okay. Next slide, I think. All right. So that's kind of my very short, high-level run-through of kind of the ABCs, some of the foundational constructs that we know are important within teams. There's also been a lot of work done on team development interventions and what can we do when some of these knowledges or the behavior, the processes or the states begin to falter. And so what you see here, I'm not going to go through all this because I don't have time, but what you see here on the left-hand side are some of the team development interventions that exist. There are more than this, but this is a sampling of them. In the middle is kind of a description of each one of those. And then on the far right-hand side, you can see that there are some interventions that are targeted at inputs, that's the I, some that are targeted more at processes or outputs or just processes. I'll highlight a few really quickly. So one that I'll highlight is team charters. So I talked about oftentimes within teams, when you talk about teams out in organizations, then oftentimes there's a problem with roles and expectations being clear throughout the team and who's going to do what. And a team charter is a really good way to structured activity where the team sits down and clarifies those expectations regarding team functioning, processes, norms, who's going to do what, how are we going to manage our performance processes, and this collaborative intervention that all the team has buy-in in, and is often revisited because that might change as the team progresses over time. We also talk about team building, which originally this would be your ropes courses and stuff like that. It has evolved to where it does sometimes target those interpersonal skills, but it's also been used to target goal setting, to target problem solving, and those interventions that tend to target those two things tend to be shown to be much more effective. And then we have team training, which encompasses a whole lot of stuff. Basically, team training programs tend to be things that are focused on any of those processes, improving those processes. So there's some very specific ones like coordination and leadership training. There's other ones that are through resource management training. This is basically focusing on 4 or 5 teamwork skills. It was originated within aviation. It's now been migrated. The name changes, but it's been migrated. If anyone's familiar with team steps, that would be an example of that. It's a migration of originally what was crew resource management training. Next slide. So kind of in conclusion, we have an awful lot of knowledge on what makes teams effective, maybe less so on what breaks them. There's been a lot of tools developed, and I know I didn't have time today to go into this, but the methods core is always available for consultation. There are methods of communication analysis, measurement techniques and tools, and instructional strategies. Where we're going, so if people are looking to make an impact, unobtrusive metrics, we still rely an awful lot on self-report mechanisms, dynamic assessment. So how do some of these things change over time? And then because of that dynamic assessment piece, we begin to try and incorporate tools from other areas such as social network analysis. People are looking into machine learning algorithms. We focus a lot on communication within teams, which is very intensive to actually code by hand. And then I think my last slide is, go ahead and go to the next one. So what we've tried to do, Lauren mentioned this earlier, was try to say, okay, well, how can we infuse some of the team effectiveness research into implementation? And so we developed this conceptual model within our proposal, and within the RFAs, if you decide to propose, you're asked to kind of fit your ideas kind of within this concept. And you'll probably get some more examples as the talk goes through. But if we start from the left-hand side, you start off with your clinical or your service evidence-based practice, and normally you think about your implementation strategy. Here we're saying, okay, we'll go beyond that and think about the context, and is there an actual team component to the delivery of that implementation strategy? For example, if there is, then think about the member characteristics, the team characteristics, and the task characteristics. And kind of if I jump one, given those characteristics, what are the challenges that they might pose for some of these constructs that I just talked about? Those are the team mechanisms you see there in the middle. Based on that, you develop this kind of team enhanced implementation strategy serving to target some of these things, which hopefully therefore leads to better implementation and clinical and service outcomes. And I think that is the last slide on my deck.
Thank you, Sean. We appreciate that overview of team effectiveness and our model. So I think I'm turning it over to Nicole.
Yes, thanks so much. Very, very helpful, Sean. So I'll spend the next maybe 8 or so minutes just doing a very brief primer on dissemination and implementation research. And just as a reminder to us all, we expect that in our high quality submissions for our RFA that we'll see both integration of team effectiveness research and implementation science concepts and methods. So let's go to the next slide, and we're going to check in with you all. Hopefully you're still with us. Please complete this poll here. What's your current level of experience with dissemination and implementation science? D&I that I'll refer to. I see us completing, which is great. Maybe another 10 seconds. Oh, this may be it. Okay, I think we have everyone. So looks like we have about 60% with beginner D&I experience. Oh, sorry, 67%. And then another third have intermediate experience, and then a few have advanced, or actually, maybe no one has advanced D&I experience in our participants. That's okay. This just helps us. So again, sort of a mix of experience with both team effectiveness and D&I research. So let's move on. Thanks for completing that, everyone. So this is a definition just to set the scene with you all. This comes from the National Institutes of Health program announcement that has a standing dissemination and implementation science set of mechanisms. So we like to use this one. It describes dissemination and implementation research as a field that intends to bridge the gap between research, practice, and policy by building a knowledge base that's hopefully generalizable about health information, effective interventions, new clinical practices, programs, guidelines, policies, and those that are communicated and integrated within routine public health and other healthcare service settings. Let's go to the next slide. So dissemination implementation science is a cross-cutting translational science. So here we have a figure that describes the translational science spectrum, starting with T1 research, which is really focused on, can we develop a solution to a public health problem? Usually involves sort of bench-side research. And then as we move along to the right-hand side, we get even more applied, and the questions are focused on based on these solutions that we've come up with, how does it improve public and population health? Dissemination and implementation science often focuses on questions related to the T3, T4 practice and public health impact questions, but we're hoping to encourage even more proposals and thoughts about using implementation science across this full spectrum from bench to bedside and beyond. Next slide, please. So there are a few really key ingredients to D&I research, and I'll spend just a bit of time talking about a few of these. So the kind of the hallmarks of dissemination implementation research includes selecting an evidence-based intervention, and then thinking about how to use a dissemination implementation science theory model or framework to design the project and evaluate it. Also includes thinking about implementation strategies. So how are you going to get people in places to use your evidence-based intervention? And then of course, how are you going to evaluate the success or process of your implementation approach? At the heart of all of this, of course, is meaningfully engaging relevant and invested partners who have important priorities and insights about the implementation process. So let's go to the next slide. And this is a table here that shows different ways that implementation strategies have been defined. I like sort of a combination of them that really describes implementation strategies as deliberate methods or techniques to enhance the adoption, implementation, and sustainment of clinical programs or practices, those evidence-based interventions. Down below, we have some very nice language that Jeff Curran developed to make it very easy to understand the difference between the evidence-based intervention and implementation strategies. So the evidence-based intervention program or practice, we can sometimes think of it as the thing. And then the implementation strategies are the stuff, again, the deliberate stuff we do to try to help people in places do the thing. For our RFA, we are wanting you to think about how to use team-based implementation strategies, many of which Sean provided a preview of earlier. Next slide here. Great. So the third ingredient in high quality implementation research is selecting and then applying a theory, model, or framework. We have definitions here of theories, models, and frameworks. They're often used interchangeably. They do have some differences. Theories are generally specific and predictive. They're really focused on hypothesis testing. An example in the D&I world is the diffusion of innovation theory. Models are often very specific and prescriptive. They often have steps involved in a very kind of systematic process. An example of a common D&I model is the ADAPT-IT model, which includes kind of 8 specific steps about adapting an evidence-based intervention for different settings. Frameworks are very comprehensive often, and they help organize different concepts. The user can sort of decide how the different concepts relate to their project and kind of piece them together in a coherent and relevant place for their project. On the next slide, I'll just remind you that we've made it easy for you. And for this RFA, we encourage you to use the conceptual model of team effectiveness for EBP implementation. Sean did such a beautiful job explaining it that I won't re-explain it here, but we do expect that you use this model. Obviously, within the 1-year scope of a pilot study, you can't test or kind of think about every single one of these concepts included, but we do want you to talk about how you might in a future application, or if you're using secondary data analysis, how that parent study maybe thought about some of these concepts. Okay, next slide, please. And then finally, and importantly, we do expect you to be talking about how you're engaging partners throughout the process. Again, if you're using secondary data analysis, please do describe how different partners were engaged in other aspects of the study design, data collection, or interpretation. Next slide, please. We have just a couple of slides here about resources that you can check out. This is a really comprehensive paper with measurement resources for D&I research. On the next slide, we remind you that the instrument review project through the Society for Implementation Research Collaboration has a nice repository. They anchored their project in another implementation framework called the Consolidated Framework for Implementation Research, CFR. It is publicly accessible now, so there's no paywall. So you're welcome to review that inventory. And then, of course, we have some resources on our InStep website. We've added more details about using our conceptual model, and I think we have some additional resources about team effectiveness research. Finally, I think this is my last slide, our D&I Science Center also has a couple of one-pagers about just definitions of D&I research and other ways that you can access training. And I think with that, I'll turn it over to Marissa.
Yeah,
Thanks so much.
Thank you, Nicole. So we have about 14 minutes, and we want to make sure we talk about the specific RFA and this pilot project, the grant, the award, the aims, how you might submit, and so on. So I will just preface this by saying, so I know we're running a little bit short on time. However, everything that's on the slide deck is in the RFA itself and on the website. So please feel free to, access the website. You can ask us for the RFA if you don't already have it. We will be making these slides and the recording of this presentation available as well for you to access at a later time. Okay, so let's jump on into it. So the the aims of the pilot funding, we have 4 main aims. One is, as mentioned before, we want to stimulate dissemination and implementation research that's focused on optimizing team effectiveness for these community-based systems that serve children with mental health needs. Another aim is to generate data that will lead to future successful grant proposals and applications. So perhaps this could be used as pilot data for a subsequent, R34, R01 application, a K award application, so on. The third aim is to support the career development of early career investigators, so particularly among individuals from groups underrepresented in federally funded health services research. And the final aim is, of course, to have a public impact on EBP implementation efforts in community care settings. So the pilot project proposals will be reviewed based on 2 criteria. One is the typical NIH scoring criteria, where scores range from 1 to 9, with 1 being a high impact proposal, 9 being a lower impact proposal. And then we also have a community-based review where proposals will be rated on 3 criteria that relate to the community impact. And all applications will be reviewed by at least 4 reviewers, 2 more research-based reviewers, and 2 community reviewers using these scoring systems. So if you're not familiar with the NIH criteria, these are the categories that are used when rating proposals. So they are rated on significance. So what is the quality and the scientific potential of the project? They're rated on the investigators. So what is the likelihood that the investigators have the potential to be successful with the research endeavors and have successful research careers? They're rated on innovation. So how innovative is the proposal? They're rated on the approach. So how sound is the research, the research design, research methodology? In this particular case, we might pay particular attention to how those constructs in the team effectiveness conceptual model, how they're being addressed, what sorts of questions are you answering about that model? And then the environment. So is the proposal taking place in an environment that's going to be conducive to the success of the research? For the community-based review, as I mentioned, they will be rated on 3 criteria: the strength of community engagement, how engaged are the community partners in the design of the research and the conducted in how the research is carried on. The impact on the community. So is this research, does it have the potential to have a positive impact on the specific community that is proposed? And then impact on human health. So how important is this research for improving human health in the future? So I want to get into the sort of nitty-gritty of the application steps. So first, you should know that we will be collecting applications via Qualtrics. So there is a Qualtrics link that you can click on, and you will basically be uploading all of your materials to Qualtrics using this link here. If you have any issues with that, of course, please reach out to us with that email address on the screen, and we can assist you with that. You will be uploading an application package that contains these 6 components. So you'll have a proposal narrative, community impact statement, dissemination plan, biosketches, budget, human subjects report. So let's get into the proposal narrative. This is kind of the typical research application that you may be familiar with. So this proposal narrative will include a 5-page application, the first page being a specific aims, and the remainder being background and significance. That's approximately a page in length. Some preliminary studies or data collection or analysis, if applicable, that's also approximately a page. The research design and methods, so that would be approximately 2 pages. And then we want you to include references, though those references will not be included in that 5-page limit. And again, as was mentioned many times already, you must incorporate this model into your research design in your proposal. You need to be addressing things that are included in this model here. This should guide your research. A community impact statement is also included in this submission package. So this is a 1-page statement articulating the community relevance or impact of your proposal. So you'll have a title, and we want this to be written at about an 8th grade reading level, so not scientific academic language here. And you'll be answering the questions that are detailed on this page here. So how are you engaging with the community of interest? Will multiple parties, the academic researcher partners and the community partners, will they both benefit from the research? Does the community that you're engaging represent the population of interest, and so on? Again, I'm trying to breeze through these quickly, as quickly as possible. You'll also be submitting a dissemination plan. So this is a 1-page document that outlines your plans for follow-up grants or proposals, any dissemination products, like if your study is going to result in any reports that will be shared with community partners, or any toolkits, publications, presentations, that sort of thing. The 4th thing that you'll be submitting is a biosketch. So we have a link here to the format that you will be using for submitting a biosketch. It's like any biosketch if you've submitted research elsewhere or proposals elsewhere, same exact format, NIH style biosketch. And this would be of all of the investigators that are part of this project. The 5th part of the application is a budget. So you will be submitting a budget for your project that includes both direct and indirect costs. And we ask you to use the NIH budget form that's linked on this page right here. The funding period is 12 months. So you want to consider that when drafting your budget. The 6th item is a human subjects report. So if your project intends to recruit human subjects, you are required to submit a human subjects enrollment report form, and there's instructions linked on this page on what exactly that should be. For projects not recruiting human subjects, we just want you to upload a document that provides a brief explanation, like 1 to 2 sentences, describing why it's not considered human subjects. And although not required by the application deadline, we really want to encourage you to submit IRB applications as you're submitting your proposals, because funding will be contingent on receipt of IRB approval. Okay, so we have some key dates listed here. And again, all of this information is available on our website and in the RFA. I do want to allow us some time to answer any questions that you may have. So I'm gonna just pause right here and open the floor for any questions from any of you.
I do have one question. Any restrictions on whether the team partnerships need to be US based or could be internationally based?
They can actually be internationally based. We've been asked that as well. I don't know if we've included it in our slide deck, but provided the partner sort of meets designation as like an international partner, they can be included.
Yeah, it just needs to be justified.
I have a question.
Yeah.
I know the center is focused on children's mental health. So I just wanted to clarify whether the proposals needed to specifically be about like individuals under 18, or if they're like, what does it mean by child?
That's a great question. Lauren, I saw you unmute. I didn't know if you were going to respond. I'm happy to respond as well.
Go for it.
So we are interested in the service systems that serve kids and including transition aged youth. So for example, we have several projects that focus on the child welfare system, and they may actually be working with the parents or resource parents for kids. So we sort of have a broad age range of potential beneficiaries of high quality mental health services, but we're more interested in the systems that may be providing services to those individuals.
I'll just add that, you know, I think that transition age youth, we're not setting a specific end date on transition age youth, and so different systems. So schools may have a different cutoff than TASE services within mental health, or different medical systems might have different cutoffs. So we as a center don't have a hard and fast end date or age for transition age youth.
Okay, perfect.
Again,
Thank
it
you.
just needs to be justified as far as why that specific age range is appropriate.
Okay, thank you.
Well, I know we have about, well, we no longer have any more minutes, but I want to invite any and all of you, if questions do emerge later, please do reach out to us, and we're happy to help you in any way. As mentioned earlier, the Methods Core absolutely is happy to meet with you for some consultation on your pilot project proposals. We can help guide some of the research design, the measurement, and so on. So yeah, thank you for putting that information in the chat. You can email the InStep group. You can go to the website, request any of those services. Happy to help.
Thanks, folks.
Thank you.
Thank you.